Thank you so much for tuning into our best practice series for medical providers working with refugee and immigrant youth and families. This is one video in a larger series hosted by the Trauma and Community Resilience Center at Boston Children's Hospital. Each short video will highlight experts in the fields of medicine and psychology who work with refugee and immigrant youth and families. We are so grateful to SAMHSA and the National Child Traumatic Stress Network for their support in making this series happen. And in this video, we will be hearing from Dr. Nirali Butala. Nirali Butala is a pediatric hospitalist in the intermediate care unit at Boston Children's Hospital and an instructor in pediatrics at Harvard Medical School. She is the co-chair of the AAP Section on Hospital Medicine Global Health Subcommittee and a member of the AAP Section on Early Career Physicians Advocacy Workgroup. She worked closely with the Trauma and Community Resilience Center to help develop this best practice series. Her non-clinical interests are in legislative advocacy, value-based care research, and global health and immigrant and refugee health. And I will now pass it on to Dr. Butala.
Thank you so much. So I'm going to be talking today about physical and laboratory evaluation of newly arrived refugees and foreign-born immigrant children. My objective is to provide basics on an initial evaluation for a recently arrived child that can be used in any setting, the ED, inpatient, or outpatient. In many countries, the concept of a screening examination and preventative care may be unfamiliar practices, so it can be helpful to introduce these concepts and explain why we screen patients before delving into the visit with the family. Children with refugee status are more likely to have undergone pre and possibly post-arrival healthcare screenings, and they may already be linked in with insurance coverage and benefits. Children with asylee, unaccompanied minor, or undocumented status may not have those same resources, and there are other videos in these series that explore those definitions further. For many of the issues that we discussed today, there are options to tier the testing or to give presumptive treatment without screening, and we'll discuss how you can tailor your approach to your patient based on their history and their access, as well as your practice setting. And most of the information in this talk comes from the AAP Immigrant Health Toolkit, that's linked here, and the CDC Refugee Health Domestic Guidance website, also linked here. My goal is to provide a basic overview that can help get things started for children as they establish their medical home. But you can refer to these resources for more in-depth information. The basic history framework should be similar to that of any child, including past medical history, past surgical history, family history, vaccinations, etc. But here I highlight some key history points that may be different from your typical practice and important for identifying infection and chronic disease risk factors. So in the birth history, make sure to ask about the setting of the birth, whether it was at home or at a medical facility, and any complications following the birth and procedures following the birth, including female genital cutting, which we'll talk about later. Ask about a migration history, understand where they were born and a timeline of any countries they transited through to get to the US and what kind of setting they stayed in when they were in those countries. Of course, obtain medical records if they have any, and ask about complementary or alternative medications. The CDC pages have some really useful country or region-specific examples of high-risk exposures to ask about, and I'll show you some of those later. A dietary history can be useful, especially one that's really thorough, because it can provide insight about nutritional deficiencies. And a social history is important as well. There are other talks in these series that will explore more about how to use trauma-informed methods to obtain a thorough social history, so I'm going to refrain from spending time on that during this talk. Development and mental health can be challenging to assess, especially in an acute care setting like the ED or during an acute hospitalization. But these are really important to identify and connect patients with resources early, especially if that patient does not yet have a medical home and this is their first presentation to care. For the purposes of this talk, though, I'll focus on the lab and physical evaluation. I'll start by discussing infectious diseases, starting with the ones listed here. So all newly arrived patients should have tuberculosis testing, regardless of any prior BCG vaccination. In patients less than 2 years old, you have to use a tuberculin skin test or a PPD. And the downside of this is that they need to see a provider within 48 to 72 hours for follow-up of the result. In patients older than 2 years old, you can use the interferon gamma release assay, a serum test that's just a one-time test. If they have any signs or symptoms of TB, make sure to get a chest x-ray as well. For any patient, regardless of the results, should repeat TB testing in 6 months because things like malnutrition or chronic disease can lead to anergy, which can cause a false negative result. Next is parasites. So the most common parasites are Ascaris lumbricoides, whipworm, and hookworm. The presentation can range from completely asymptomatic to any degree of nonspecific GI symptoms. And you can see anemia or eosinophilia on a CBC. You can test for all three of these together with the stool ONP test, but you do need 2 to 3 samples of the test, each greater than 24 hours apart at minimum. You could also treat presumptively with a single dose of albendazole, but make sure if the patient has any history of seizures or neurologic deficits to obtain neuroimaging to rule out neurocysticercosis prior to administering the albendazole. There are a few common parasites that are not captured by the stool ONP. The most common of these is strongyloides. This one's difficult to detect because it sheds transiently and has high rates of autoinfection. You can see transient GI symptoms, larva currens, which is the skin finding shown here, where the parasite is migrating under the skin, or transient pneumonitis. Since it is so inconsistently detected in the stool, the best way to test for strongyloides is to use the serum IgG. You can also just treat presumptively with ivermectin, but here, make sure that if the patient is from a low endemic country, you rule out co-infection with that prior to administration of the ivermectin. Schistosoma is another parasite that's not captured on the stool ONP. This one has some unique symptoms, like the rash shown here that causes these characteristic red papules, hepatomegaly, lymphadenopathy, GU symptoms, and hematuria on a UA. Like strongyloides, the best diagnostic test is a serum IgG, but you can also provide presumptive treatment with praziquantel. Again, make sure that there is no neurocysticercosis concern prior to administering the medication and monitor the patient closely afterwards because it's not 100% effective. And one last parasite to keep in mind is Giardia, which you can test for with the stool antigen study. Giardia is less likely to be asymptomatic, so you can reserve testing for patients with GI symptoms, especially large volume, foul-smelling, or watery diarrhea. This is a table from the CDC Refugee Health Domestic Guidance page that I shared earlier, and it outlines the doses and contraindications for each of these presumptive treatments. As you can see, they're single-dose regimens, so that can be really helpful in situations of unclear follow-up. Moving on to hepatitis. For Hep B, all newly arrived children should have hepatitis B testing, unless you have really good prenatal or parental records confirming no maternal infection of hepatitis B. You should send the surface antigen, core antibody, and surface antibody, but as long as the surface antigen is negative, you can complete the vaccination series regardless of the antibody results. For hepatitis C, test only if the patient has risk factors, like cutting, transfusions, surgeries, or tattoos. Hepatitis A, D, and E do not require routine testing or treatment. Next, we have malaria. So the most common, but not inclusive, symptoms of malaria are flu-like symptoms, splenomegaly, jaundice, and anemia on a CBC. Patients can fall into 3 buckets here. They can be, if patients are from sub-Saharan Africa, testing or presumptive treatment is recommended. Keep in mind that refugee patients often received these things before arrival. So if they did so, no further testing or treatment is necessary. If patients are from malaria endemic areas outside of sub-Saharan Africa and they have symptoms of malaria, you should test them. There's a couple different options for testing, including 3 days of a thick and thin smear, a quantitative PCR, or a rapid test. And it can be helpful to talk to your local infectious disease or public health teams to figure out what the best option is in your setting. If patients are from malaria endemic areas outside of sub-Saharan Africa and are also asymptomatic, there's no indication to treat or test for them. And the guidance here on the CDC page goes into more detail. And lastly, we have STIs. HIV and syphilis can both be transmitted congenitally, so all children should be tested unless you have good prenatal or parental records confirming no maternal infection and your history has no risk for horizontal transmission. Gonorrhea and chlamydia testing is recommended in all pubertal children and younger children if there's any concern for sexual abuse on your history. Moving on, we're going to talk about nutrition, so including CBC, lead testing, vitamin deficiencies, and then I'll just review some miscellaneous lab tests and exam findings to keep in mind. The CBC can provide a lot of information, so it's recommended in every child. If a patient is found to have anemia on their CBC, iron deficiency is the most common cause globally, so iron supplements should be started presumptively. And you can decide whether to send confirmatory testing with ferritin to evaluate their iron stores. You can also consider an electrophoresis for hemoglobinopathy or thalassemia evaluation. The map here shows regions where these diseases are more common. Keep in mind that parasites and malaria can worsen anemia, so if you have high suspicion for those, they may be contributing to the anemia. If the anemia is normocytic, you should consider G6PD testing, especially if they have any signs of acute hemolysis during periods of illness or with certain medications. The CBC can also show you if there's eosinophilia, which would be an absolute eosinophil count greater than 400 or greater than 5% on your differential, and this should prompt you to complete a more thorough parasite evaluation. And if there's thrombocytopenia, that can guide you towards malaria testing, HIV testing, or other viral testing guided by concurrent exam findings and history findings. All children should also be tested for lead levels on arrival, and it should be repeated in everyone after 3 to 6 months in the US because higher lead levels have been demonstrated in resettled immigrants and refugees in the US. Iron deficiency likely increases intestinal absorption of lead, so as you treat anemic patients, that should also help to explain and address any elevated lead levels. And common sources of lead exposure internationally are shown here. They include leaded gasoline, cosmetics and home remedies with lead, car batteries that are used domestically as a power source, leaded cookware, and pollution. And this is another table from the CDC page, and it outlines lead exposure risks unique to various countries or regions. It can be helpful to refer to in your initial history taking or once you identify an elevated lead level. Next, we have vitamin deficiencies. As we mentioned earlier, a thorough dietary history can be crucial in elucidating information about vitamin deficiencies. You should also ask or note any generalized symptoms such as weakness or malaise, and maintain a higher suspicion if you identify developmental delays on your history. On your exam, some generalized signs of malnutrition to assess are hair depigmentation and dryness, poor dentition, impaired wound healing, and dermatitis. Let's discuss some specific vitamin deficiencies. So vitamin D is the most common deficiency both in the US and abroad, and especially think about this in patients who keep their skin covered whenever they're outside. Signs on your exam for vitamin D deficiency can include frontal bossing, craniotabes with widened sutures, delayed tooth eruption, rachitic rosary of the ribs, and bowing of the legs, which is shown here. Some other deficiencies include vitamin A deficiency, which, although less common, does still occur, and you can ask about decreased night vision or look for xerosis or bitot spots on your exam. Those are shown here, and they're the dry, foamy, cloudy lesions on the cornea. Vitamin B12 should be considered in any vegetarian or vegan patients and anyone with a macrocytic anemia on their CBC. You can look for diminished proprioception on your exam. And lastly, we have vitamin C deficiency or scurvy. Although it's far less common nowadays, it does still occur, and some common findings include ecchymoses, petechiae, bleeding gums, hyperkeratosis, and the corkscrew hairs. Some final tests to consider include a newborn screen panel according to your state's guidelines, a urinalysis, which can provide useful information like hematuria, which we mentioned earlier is a sign of schistosomiasis, or proteinuria, which can suggest underlying renal disease, thyroid studies in anybody less than 6 to screen for congenital or iodine-deficient hypothyroidism, and an HCG for pubertal females. Some other exam findings that might not be a part of your routine exam include a hearing and vision screen, regardless of the patient's age or your practice setting, a dental exam, especially if history has decreased dental care compared to our US standard, lymphadenopathy, which can point you towards infections, a goiter, which can prompt the thyroid testing, a murmur, which always makes us think about anemia, but should always also make you think about congenital heart disease, heart failure symptoms, hepatomegaly, which can suggest hepatitis or schistosoma, amongst other things, versus splenomegaly, which can make you think more about malaria. Jaundice, again, can prompt you to test hepatitis, and especially if they're acutely ill, should make you think about G6PD. A rash, look for the characteristic scabies rash, which is common and treatable, or those parasite rashes I showed you earlier. And tattoos, which should trigger hepatitis C testing. And one part of the exam worth mentioning is the GU exam, specifically female genital cutting. So this should be discussed prior to the GU exam with a non-judgmental and straightforward approach. Include it in your series of questions, either about your birth or your surgical history, and be knowledgeable, cognizant of your bias, and aware of your reaction as you work to establish a rapport with the family. Mutilation, cutting, circumcision, and purification are all appropriate terms, and you should mirror the caregiver's terminology as you talk about it. You should mention to the family that the procedure is considered illegal in the US. And about the exam in general, you can defer it during that first visit if it's not within the family's comfort, and you should just document it as so. If you do proceed with the exam, be aware that in certain cultures, patients may not be comfortable with the male provider, nurse, or interpreter in the room during the sensitive portions of the exam. So that was a very thorough lab and comprehensive physical. But as we discussed earlier, this may not be practical during your first visit. A tiered approach can be really helpful for a patient with limited coverage or resources, or for a patient who you are seeing in an acute care setting who may not be under your care long enough for repeat testing or discussion of results. One useful tool to help stratify and prioritize the evaluation is the CareRef tool from the Center of Excellence in Newcomer Health in the Minnesota Department of Public Health. It's meant for refugees, but it can be used for all newly arrived children with the understanding that it should act just as a general guideline. I have the QR code to the tool here, and this is a screenshot from the first page. As you can see, it takes into account the state where you practice, the patient's host country and their country of birth, the patient's age and their sex, and any prior medical records, and it provides recommendations on where to start your treating and how to proceed. This table is from the AAP Immigrant Health Toolkit, and they tiered their approach here as well. These are all tests that we discussed during this talk, but they are listed in order of what the AAP considers priority. The most important tests for every child, as you can see, are the TB testing, the CBC with differential, and the lead testing. For Hep B, you should send at least the surface antigen to rule out an acute infection and to proceed with immunizations. For parasite testing, at least test or treat for those 3 most common parasites and strongyloides. That should be the priority. And lastly, ruling out congenital or transmitted HIV and syphilis should be completed if you're able to. The remainder of these tests are all considered optional, but the toolkit footnotes do provide more guidance about when to test for each one. Just to review, these include the pregnancy testing and gonorrhea chlamydia in all pubertal teenagers or younger kids if there's concern for sexual abuse, Hep C screening if they meet risk factors, a newborn screen per your state guidelines, thyroid testing in anyone less than 6 or with symptoms, Giardia testing if they have symptoms, hemoglobinopathy and G6PD eval if they have symptoms or concerning anemia, vitamin deficiencies based on their dietary history and exam, schistosoma testing if they have hematuria, GU symptoms, and you can treat that with praziquantel presumptively, and malaria testing or treatment if they're either from sub-Saharan Africa or from another endemic area with symptoms. And as a hospitalist, I just wanted to take a final moment to emphasize the importance of starting this evaluation with this approach, regardless of your practice setting. Patients are often seen in urgent cares or hospitals as their first presentation to care in the US, and these providers have a unique opportunity to have a conversation with the caregivers about the importance of the screening evaluation, early treatment, and establishing or utilizing a medical home. Thank you for your time, and thank you to the TCRC and the NCTSN teams to allow me to speak today.
Thank you so much, Dr. Butala, for sharing your expertise with us. And we want to just thank all of you for watching. If you're interested in learning more, please visit our YouTube channel where there are more videos. The link and more information is in the video description. Thank you.